Let me introduce our first session. Lucius Savage, who's the Chief Privacy Officer at ONC at HHS, and she's having a conversation with Adam Tanner, who's a fellow at Harvard University.
Thank you very much, and good morning, everyone. I am based at the Institute for Quantitative Social Science at Harvard, but my work is mostly about the human face of personal data. And I had a book that came out last year called What Stays in Vegas, which is about the commercial use of personal data. And I'm now researching a book on the business of medical data and how it's been commercialized over recent decades. One of the interesting things I wanted to talk to today about was the background of electronic health records. And as part of my research over the past year, I've looked at some of the early pioneers in electronic medical records in the 1960s. Men like Larry Weed and Warner Slack and others. There were a number of people already in around 1967 that were beginning to adopt early computers to electronic medical records. And patients would go in there and enter in information and have access to it. In the language of the era of the 1960s, Warner Slack, one of the pioneers, was talking about patient power, that patients would be empowered to have their records, to be able to use it, and doctors would be also empowered with this great new knowledge. Of course, almost 50 years has passed, and that vision and that great era of hope, just a year or two before we landed a man on the moon, when everything seemed so limitless of what we could achieve, has not been yet achieved. And I went to go see another one of these pioneers, Larry Weed, who was a doctor who's done some pioneering work on simplifying physician notes, and also around 1967 was computerizing records from patients. I went to go see him. He's now 92 years old. He lives in the woods by himself in Vermont and is incredibly fit and full of energy. And I said to him, well, it's been a long time since your innovations. How do you feel about what's happened in the intervening years? And he said, if I was a suicidal type, I would have committed suicide a long time ago. But we have a chance to update what's happened in all those years since in a conversation with Lucia. Thank you very much for the opportunity to talk today. And I wonder if you could take initially the big overview. What has happened? Why are electronic medical records that the patient has access to so long in coming?
I don't have the definitive answer on that. I have some guesses. I've been working in healthcare a really long time. I think a lot of the focus, both not only with Hipaa when it was enacted in 1997 and subsequent regulations, and with high tech, was about the guts of the system, the stuff that makes the healthcare system run every day, so that we don't have to go in there and make it run for us. Like, I have an EOB sitting on my desk, and I'm like, why is there an extra $10 charge in there? Now I have to call my insurance company and figure out all that kind of stuff. So we want a system that sort of runs where we don't have to intervene and spend our precious time on that every day. And that's been a large part of the focus. That's definitely the focus of high tech. And one thing that's important to remember about high tech that people kind of forget sometimes, it was part of a giant stimulus package, right? It was February 2009, the economy had tanked. And the President and Congress collectively were looking for solutions that were kind of already in a tidy little package that could force money out into the economy in a Keynesian stimulus way. We had TARP, we had high tech, we had road building, we had all kinds of stuff, and high tech was that. So, $29 billion later, we actually did stimulate a whole new sector of the economy. It's up to the public at large to figure out if they've gotten the value out of that they wanted. But that was really a key part of high tech, was, right, get the money in the economy, advance the technology at the guts of the system. So now, then we have, in 2010, we get the Affordable Care Act, and now we've got more people have coverage, and we're not here to debate that today, but what I was going to say is there's a point in the not too distant future where these two things start to have a confluence, where we start figuring out how to bring the best practices in integrated care to people, to preserve health when they have it, to help them regain health if they need it, to give them the social supports they need in their communities to stay healthy. And that happens in a combination of how the stakeholders work together, so patients, their caregivers, their physicians, their practice extenders from nurses on down to social workers, and the information those people have that they're working with. And there are going to be people who don't want that kind of care, and there are going to be people who want it and desperately need it and can't have it. And so we have to have a system that kind of makes all that work together. And that's coming sometime in the future with the Secretary's delivery system reform efforts. That's a pretty big step. And it's sitting on a bed of information that needs to be where it needs to be for the patient's care, but we have a long way to go.
How long do you think it might be before the typical person has easy access to their medical records wherever they may be, if they're on a trip to Canada, if they're in a different city, so that in an emergency situation a doctor could quickly access the records? You
know, they hand out crystal balls when they give you a job at ONC. Actually, I do not have a crystal ball, and I do not have a prediction for that. I can say this about that, which is we're working really hard to make sure patients right now understand the rights they have to access their data and to ask that data to be sent to third parties. I don't know if Jocelyn talked about that yesterday, but we're in constant dialogue with OCR about that, and some of our technological rules are designed to enable that. How long is it before, well, I saw President Bush at HIMSS, Bush 1. He founded ONC with an executive order, and his vision was, he was asked about this, we thought everyone would just carry it around on a thumb drive. How many of you still use thumb drives every day in your life? Okay, a fair amount. I haven't used a thumb drive in ages. But even if you had that thumb drive and it was on your, I don't know, on your wrist, and you were jogging and had your accident and the EMT could rip it off and plunk it down and get your record, I think that's what Bush was thinking. I'm not sure that's what we would want to have happen. Thumb drives can be stolen, they can be polluted, all kinds of stuff. They can pollute systems that they're connected to. So what's the more secure alternative to that thumb drive is kind of what we're thinking about for the future.
So what are some of the obstacles on this process? Because all of us have probably encountered situations where you have a dental x-ray one place, you have to go somewhere else, they won't forward it on, you have to do some small test, they want you to repeat it. Just the most simple things that we as patients try to do are often flummoxed by just a simple request, please send that x-ray, the dental x-ray forward.
We, in our draft interoperability roadmap, and this was actually echoed back to us as, boy, you got it right, we diagnosed that we thought there was a lot of misinformation about when physicians could release data to patients. I've had that happen to myself in my family on numerous occasions where caregivers can get it, but I can't. That's pretty frustrating. So we have a plan for that, and we're executing on it step by step. It's a very complicated process when you execute on educational materials in the government, because you want to make sure you get them right, because people are really going to rely on them.
But again, the question is, can I send my dental x-rays from one place to the other? The plan is what exactly?
It's a complicated thing. Theoretically, you should be able to go to your dentist right now and say, please send my x-rays to such and such a place. Right. And theoretically, they're supposed to say, okay. Now, there's time limits, and they have 30 days, and they can extend it. And if you're in a correctional facility, there's certain exceptions to those rules. But you could theoretically do that today. The question becomes, if the dentist says, I didn't know that, or prove it to me, or no, how do you redress that? So that's actually Jocelyn's agency's responsibility, is to redress that. But this happens all the time, every day. We had testimony just last month at our policy committee. One of our, cognoscenti, right? Somebody in the know, does this business every day, had to take a copy of the regulations and show them to the physician, who gave them to the office manager, who gave them to somebody else, who gave them to somebody else, who gave them to somebody else, and finally they printed her record onto a CD-ROM and gave it to her.
Now, as you and I were coming in just at the start of breakfast, we ran into a professor who was complaining that at his doctor's office, records about him are anonymized and sold to other companies, and he objected. Do you think that patients should have the right to determine what happens with their data in the commercial sphere, whether or not it would be sold even on an anonymized basis?
Well, I want to make a couple of distinctions. So we have to really distinguish, because there's rules for all of this. So there's one set of rules that applies in the stakeholder context. You guys, I think, generally know that. Physicians, hospitals, health insurance companies, clearinghouses. There's a different set of rules that might apply to sort of your generic commercial internet company, a Facebook, a Twitter, et cetera. And then there's a third set of that are really not very well defined that apply to those retail electronic information activities. They're not healthcare. They're not clearly an internet company like Facebook, and they may be collecting personal data about you. So that might be, Fitbit, a Map My Ride, the stuff that we have. If we have smartphones, we might be having data collected about us on our smartphones. So different rules apply in different contexts, and that's pretty fundamental to the way we regulate data in America. We regulate it by sector. Whether that's the right way to do it, Europe does it a different way, is something that is appropriately debated and has been debated for a long time.
But I guess the question that this professor had raised was, you go to the doctor, should he be able to sell those records on an anonymized basis? You have a blood test, should the blood test company be able to sell those? Should your insurance company be able to sell the records about you?
I'm not the OCR, so I'm going to speak a little bit out of turn because they are the official interpreter of that, but I'll just give you my best understanding based on my personal knowledge, which is HIPAA allows people who have data about you to de-identify it. We can get into discussion about de-identification, and I know you guys want to go there, so just hold your horses. It's allowed, and then that de-identified data can be released at cost for various purposes. It's not supposed to be released for marketing, and there are definitions of what marketing is. So, for example, you can take de-identified data and prepare a de-identified data set and make it available for a clinical research exercise or for a quality improvement study based on, what's the hemoglobin A1C rate in my community, that kind of thing. You're not theoretically supposed to sell it identifiable, and you're not theoretically supposed to sell it in a way that leads to impermissible marketing. That being said, whatever a particular physician does, I have no idea, and if a person were concerned about that, they should email or call OCR. They have a hotline, they have a website, where you can file complaints, and I think Jocelyn said they're expecting to get 17,000 complaints in the next fiscal year. I can't even do the math on how many. What is that? 1,500 a month, something like that.
But whether or not you think with the current situation there should be some limitations or some changes in the rules, can you? Well,
my job is to really deal with the rules we have and to implement the government's policies. And if Congress is considering changes and they ask the administration for advice about that, we give them our best expertise. That's part of our job. What the rules should be is really for you guys and the legislators to try and figure out.
But you can't share what your best expertise is right now.
I'm not going to give you my opinion about it.
About, you just mentioned the question about re-identification or the safety of anonymized data. Do you think that as computers have gone forward in recent years, more data sets are out there, that there is an increased danger that wasn't considered when the rules were written in the late 90s, early 2000s? We
have had this great exercise at ONC, mostly in December, but we're working on a process of actually trying to get some evidence about this for the administration through an open process. Probably people here in the audience may have listened in. We had hearings on this exact topic that were December 5th and 8th. The audio and transcripts are available on our website. And the experts we brought into the room were very clear that, in fact, it is so much easier to combine data sets when they all start in an electronic form that it is potentially time to rethink that. So that's something, information people brought to ONC when we asked what the answer should be. I don't think there's any disagreement that 20 years ago, if you had a printed data set that was de-identified and you took another printed data set, the painstaking process of combining those manually and the error rate of that manual combination with transcription errors and reversed numbers made it sort of a disincentive to do that. And now, of course, with computers, it's a lot easier to do that. So that's what the experts told us in this testimony.
So should people, ordinary patients, ordinary people, be worried about this wide sharing of data on an anonymized basis today? So
I'll just tell you what I worry about. So I tweet professionally. I'm on Facebook and I'm on LinkedIn, and I know the deal that I'm making when I do that. And I filter the information I'm posting to those social media sites accordingly. And all those choices are, you don't have to go on Facebook. You don't have to go on LinkedIn. You don't have to go on Instagram or Twitter or any of those things. You have to tell your physician something about your health care. And that's why we have a different set of rules for health care. I think the key thing is, do the patients understand the fundamental deal that's being made? And I think it's really important to distinguish between, for example, patients like me, right? That is a social media website sponsored by pharma. People who participate in patients like me actually know it's sponsored by pharma. They know that pharma is taking the information they put on that social media website, and they know that pharma is making business decisions and monetizing it and doing planning with it and calculating whether the drugs are working the way they're supposed to work, all that stuff. But the trade-off is the people who choose to participate in that are actually getting something of value to them in the way that they social network with people with similar health conditions. That's a fair and transparent deal, and that's where we should be headed.
So that's something that does not exist in the current information data market around medicine today, right?
Well, I mean, people have notice of privacy practices, and those notices of privacy practices conform to what's required by HIPAA. So I would say the healthcare stakeholders in general, and Jocelyn would be the one to second guess me, are in general complying with the rules that have been established through a pretty open and democratic process. So congressional enactments, 2 rounds of that, lots of rounds of rulemaking. All of that is public and open to public debate. Probably many people in this room have submitted comments in rulemaking. So if people are complying with the rules that we as a society have set up, it's not my place to say that that's wrong.
To personalize the issue a little bit, what I was going to, whether or not your data is safe out there. I spent a few minutes yesterday looking you up. And I'm not going to announce what I've looked
what I found out about you. Now you all know I need reading glasses.
But I'm going to give you little strips of paper that have these pieces of data. And I want to ask you ultimately whether all of this information combined with whatever else might be out of the medical field might make you feel uncomfortable. So this first piece of paper has your current home address, your old address, and it has your exact birth date. The next piece of paper has where you attended college and the year, your birth name, your husband's name, your 2 children's name. The next one has the church where you have gone for many years. It has where your husband works.
That's well known publicly.
This piece of paper has where you cut your hair, and it has your registration as a political party. So these are just like a few snippets of data, right? And
well, some of this isn't correct anymore, so.
You don't cut your hair there anymore?
No.
Well, because it's in Oakland, California.
That's right. I do not fly cross-country for a haircut, although I'm sure my stylist would like it if I did.
Yeah. But I'm saying these little pieces of paper, these snippets of information combined with other information, in other words, if you had health care in your former hometown in California or here and some other places, a woman of your age, anonymized, it seems like there could be a greater chance of re-identifying your data. And so giving you a very quick back of the envelope findings, I wonder if that makes you a little uncomfortable as a normal person.
I'm not uncomfortable because I can look at this and sort of go, most of this is stuff I've self-disclosed. Yeah. And there's actually isn't any medical information on here, but I'm a pretty healthy person. So it doesn't make me uncomfortable. That doesn't mean that other people might not be uncomfortable if they did this exercise for themselves. And that's why I want to really distinguish between a system, a lot of this is stuff you either have to give, like, stuff for my voter registration. There's certain pieces of information you have to do to be a registered voter, or that I've chosen to disclose, and that's sort of different, that's regulated different, a different rule system than how the healthcare system operates. It's very important to understand that difference. It's not that the concepts of privacy aren't philosophically the same. They're all grounded on the FIPS, but the business models are different and the rules are different.
In one of our keynote addresses yesterday, we heard from MIT professor Sandy Pentland, and he began by talking about amazing things that could be done with big data, and then he went on to about how easy it is to reinterpret anonymized data, and so he said one possible solution is giving people a choice about that, and he also suggested there could be ways to, because it's complicated to choose, outsourcing it to your church group, to your neighborhood group, to an alumni group, so that people would help inform. Do you think this concept of giving a choice on what to do with your medical data, even if it's anonymized, is this something that could work?
So I want to, pardon me if this is kind of a long answer, but I think it deserves a little bit of breakdown because it's complex. So it's really important to remember that some big data techniques happen in a consented research environment when in fact patients are being offered choices, and we can get more into that if you want. Other big data techniques happen with data generated from people's healthcare system, but they're not actually about the health of the people reflected in the data set. So let me sort of break that down and try to give you a couple of illustrations. Talking about the big data techniques that might derive from information that is about all of us, but is not really, it's from us, but it's not about us. We have a public policy imperative in this country to understand where high-quality health care is supplied and where poor-quality health care is supplied. And one of the ways we do that is look at things like a really early example was we had a big drive in the early 2000s to improve the rate of mammogram screening for women over 40. And the way that they figured out where physicians needed personal coaching to improve their mammogram screening was by looking at administrative claims data. What was being billed? How many patients were being billed for mammograms? So if those of you who know how this works, pardon the story, but I think it's helpful, and I use this a lot when I'm explaining this. If I go to my physician and I'm in the panel, there's 100 women in my physician's panel who are between 40 and 65 who are eligible for mammogram screening. They'll look on a fee-for-service basis to see whether, within a 2-year cycle, they got billed 100 times. 100 each identified ones. That's a perfect score. That physician gets 100 if they do mammogram screenings for all 100 of those women. But if the physician leaves some women out, they might only get an 85% score, and we do that by counting. Were there 100 women? Were there 100 mammograms or only 85 mammograms? So that's how you get a mammogram screening score. And there are a lot of reasons for the delta between the difference between the 85 and the 100. It could be a non-compliant patient. I've refused a mammogram because I don't have any genetic markers for breast cancer going back like generations and generations. And now I've self-disclosed my PHI. Right. But I'm choosing to do that. Other people may insist on that mammogram every year, whether they've gone through that genetic history or not. And so that's we want doctors to make sure women who need mammograms get them. And sometimes we have to measure what the doctor's doing using the transaction that the patient has generated to say, you did this wrong, or you could do this better. Another great example is we can use the same technique, which is actually about the doctor's way of practicing, to identify doctors who are overprescribing antibiotics, particularly in the pediatric population, which is a pretty big health hazard because we're having higher and higher resistance to antibiotics. So that's an example of a way we would use a big data technique with data that comes from these administrative transactions about patients, but we're not really interested in the patient. We're interested in what the doctor did and what they billed for it. Contrast that, and again, I said this was going to be a long answer too, a research transaction where we might be taking in survey data and biometric data, and in the precision medicine world, genomic data in about a patient, and using the same type of computer power, these incredible statistical algorithms and this powerful natural language processing to find patterns in similarly grouped biological people. Those people have agreed to be subjected to that research. So we have to sort of think about the differences of where the big data technique is being applied and how we're applying it. And then as to consent, so obviously the research transaction right now, the best way to do this is through consented research, and you know from what Francis Collins at National Institutes of Health has said and what the president has said and what Jocelyn said yesterday, we're all kind of working on how do we bring the administration's dream of precision medicine to fruit to benefit people with really serious illnesses and find cures for diseases while ensuring appropriate informed consent and appropriate privacy protections. And so that is anticipated to have a consent element in it. But in between consent and the earlier mammogram example, there are actually a lot of tools that might be used to ensure appropriate privacy protection that we're still exploring how they would work. So, people can complain about the bureaucratic processes of institutional review boards, but they serve an important purpose of providing a disinterested third party who's overseeing in part the privacy conditions under which that activity is occurring. How does that work in this brave new world of big data?
But I guess I'm not totally clear. So when data is being sent from your doctor, your hospital, your pharmacy, should it be available widely to whoever wants to use it, whether it's the National Institutes of Health, the CDC, university researchers, data brokers, commercial companies, or should there be kind of different levels for different people along that chain?
The way it works now is there are different levels for different people, and I think the system is working reasonably well. You guys all might disagree, but it seems to work in its basic functions as a healthcare system, and we have to look at whether we can still accomplish the basic function, right? Get people the care they need and make sure it gets paid for. And then B, can we improve the information so that we can have better outcomes and better health? We have very low health scores in this country. That doesn't mean it's a data free-for-all. So the current system is not a data free-for-all, at least in my opinion.
But in terms of consent, I think if you asked an average patient, do you know that your data is maybe anonymized and sold from your pharmacy, from your insurer, from your doctor, and so on, most people have no clue. And I've given public talks related to my first book, What Stays in Vegas, and this is something that is quite surprising to people. So it seems like they're not truly in the know about this basic practice.
Well, the Notice of Privacy Practices that a healthcare covered entity is required to publish is required to say whether they're allowing people to de-identify your data. That's just, if you're allowing it, you're supposed to disclose it. If it's not being disclosed, that would be an OCR issue. If a person isn't reading it, that would be, there are a lot of complexities about why people do or don't read their Notice of Privacy Practice. I read mine, but I'm in the business, and I know many people don't, and we don't read, what's on our smartphones either. We just click through because we want the convenience of the tool underneath. So people may be surprised by the question you ask, but I don't know that doesn't mean they're not being told and it isn't registering. I just don't know enough about that informational transaction on a case-by-case basis. I will say in my prior life, for every insurance company member that would call and say, how did you know I didn't have my mammogram? We counted and it was missing. There was an equal number of people who called and said, thank God you reminded me to get my mammogram. So both things happen.
You, of course, have a law degree from a very good university that helped you read those privacy policies and make sense of what...
Actually, I have to tell you, I graduated from law school way before Hipaa, practically before Al Gore invented the internet. So none of this existed back then, and no email. Only the rich people had an 8086 IBM, and there was a computer lab. So it was actually a completely different world back then.
Now, you were telling me before that your mother is... elderly and is part of an integrated system. What are some of the lessons you've learned from watching her and the care that she's received?
Sure. And I will say my mother gives me permission to talk about this, so I'm going to disclose some of her PHI, but she said, no, please do that. I like the work you're doing. So my mother is 87 years old. She's bipolar. She has chronic obstructive pulmonary disease, which is degenerative and eventually leads to either death or emphysema, and a bunch of other elderly things like hypertension and thyroid and stuff like that. And she's learned how to use her integrated systems portal in a few really distinctive ways. So somebody in her condition is having pretty regular kidney function tests, right? Once a quarter she goes in there, they take a sample and they try to figure out if her kidneys are still working. And her system has a very graphically good user interface, so she's learned to know exactly what green, yellow, and red mean on her kidney tests. She's also showed me how to use that system, so when she's been sick, I'm delegated and I have her power of attorney to communicate directly with her physicians through that portal's email function, and they all know who I am, and I've taken a point to go and have appointments with them and meet them. So one of the things that's really enabled is there was a dispute among her physicians about her kidney function. And her primary care physician really felt like her medication she should get off some particularized medication. And her psychiatrist kind of agreed. And I sort of looked at it, I'm like, what does the kidney doctor think? Let's go to a nephrologist. That's a kidney specialist. We go to the nephrologist. He opens up the portal. He sees the same 8-year history. Oh, this is when you're in the hospital and this happened. And he's got his particular perspective on it. But he was able to discern that drug A was actually making the kidneys look worse than they were because of the way drug A functioned in her biochemistry, and it didn't really mean that she had to change off of a medication that was effective. It just meant it had to be monitored, but it wasn't nearly as bad as the less specifically trained physicians had observed. And so that was a really great example of how the integrated information can help the physicians learn. Now these primary care physicians go, oh, I can go to the kidney doctor if I have any questions about this. Keep a patient on an effective medication, and by the way, this was during the Medicare donut hole, so the new medication would have been on patent, super expensive, completely broken her bank. So there was a whole financial driver here too. So that's an example of the power of particularly lab results and medication reconciliation working together in a multi-provider setting.
Though the irony is, were she to move to a different state where that company is not present, they would send her paper records. That would be it.
That is probably true, and I used to be a member of that system, and I asked for my records when I came here, and it got a big stack, which has now been rekeyed in a relevant part by my new physician into her EHR.
So again,
hopefully correctly.
That's sort of back to the question of why must it be like that? Why can't they just...
The question of, and you're asking about interoperability, isn't that?
Well, I don't even like to use the word, but just simply, why is it so difficult to transfer basic information about our health conditions to other providers?
So the technology, there's a couple of things about that. The technology has the capacity to be a lot simpler than we've made it, and ONC has a path on our sort of technological standard side to try and ease that way. For example, common clinical data set. Congress, of course, is interested in what the software vendors are charging to build interfaces, right? Because somebody has to make the two machines talk to each other, and it is much less expensive than it used to be, but prices still seem higher than they should when you look at them objectively. And then, of course, we have to actually make sure the physicians and the patients understand the public policy drivers and the patient's rights to move that data. So irony of ironies, this particular integrated system is in multiple locations, but within each region, they might be sending paper between each regions. And another irony of ironies in terms of what we as patients experience, Hipaa itself actually is neutral as to whether it's electronic or fax or carrier pigeon or telephone. So we do have a system where the fail-safe is, I can't make it work electronically, I'll just fax it, or I'll just photocopy it, print it out, and put it in a big envelope and mail it, which is what happened in my case. So there are a lot of reasons why it's hard. ONC has a charge to make parts of it easier. The parts that are about human behavior, a little harder, pretty much harder to do.
Have you studied other countries' examples? For example, yesterday we heard about Japan from Hariba Masao. Are there other countries that maybe have made a few more steps or different advances that we should look to?
Interesting question, that. So actually, my particular role has a charge to make sure we are always looking what other countries are doing. And I was talking to the Brits this week when they were here for Health Data Palooza. So interesting system. They're trying to do a lot of the similar things we are trying to do with get more comprehensive information where it best serves the patient in care. And they have their data rules are sort of ubiquitous about the data and not by sector, and therefore they have different capabilities for doing the analytics, like that breast cancer screening example I was giving you. Whereas we have sector by sector rules, and we have rules within sectors, which may mean we do one thing in healthcare and something else entirely with your Twitter account. Similarly, I was at Deb's lovely event on Tuesday night. I'm talking to some researchers from Germany. So we were talking about informed consent, broad informed consent for research, right? Is a grown-up capable, a mature, competent grown-up capable of consenting to have their donate information in a way that can be used multiple times for multiple future research subjects? For example, and I'm just making this up now, I, Lucius Savage, agree to have my data researched for everything related to melanoma. I'm making it up. And it's just about me. So that's a good question. How far can a broad consent extend? You can imagine a world, and apparently this is what I was told by the German researchers, where the German government, as a policy matter, does not think that a grown-up can competently agree to a broad long-term consent, because it's not possible to specifically describe how that melanoma research, in my example, might occur in 10 or 15 years. I don't know that that's the right answer. I think I probably could make that decision for myself as long as I could change my mind in the future. This is, again, just me personally speaking, but that's an important thing, right? Is it possible for people to make these decisions for themselves long term? The social media health sites, like Patients Like Me and other ones that are maybe not run by commercial organizations, seem to indicate that people, particularly ones with rare or complicated diseases, actually want to participate in this research process. So we have to figure out a way to enable that, not squash that learning from happening.
Should people be worried that their medical data will be hacked and abused?
Cybersecurity. So I think, everyone within the healthcare system who thinks about this recognizes that the healthcare system as a whole is a little bit immature in its security approaches compared to other data sectors. And all data sectors are subject to hack. we've had some pretty phenomenally large hacks this year. I was in the Care First hack. My sister was in the Primera hack. We have to sort of move beyond our traditional thinking about that, but we also have a bit of a different business environment than, say, the financial services. So in financial services, you don't typically find, you might find, small single office certified financial planners, but they don't have custody of money, right? They're giving you advice, and they might be doing transactions for you through other people's secure websites, but they don't actually have the custody of the cash that you've invested in your stock. At least I hope not. In contrast, in healthcare, we have this system where we have enormously large organizations, Anthem, United Healthcare, whoever, you name it, big systems like HCA, and really small businesses. Really small businesses. And they all need to be secure, and we are trying to figure out things like, if everyone meets the minimum, what else is required when you're a big flashing neon red target like a giant company? Or how can we get, I kid you not, small practices to stop putting the password on the sticky note next to the file cabinet with the password 123. Scratch it off, password 456, WordPass 789, right? That happens every day. So that's not appropriate. So we have this very diverse environment in which we're trying to raise the level of security awareness and security functionality. So yes, I think people should be thinking about it. I think people should ask their physicians. I think the first thing we as patients can do is help the medical system understand that no, in fact, you do not need a Social Security number to get commercial health care. So how many of you gave your Social Security number the last time you went to the doctor's office? Oh, good class. Everyone gets an A. I've been in rooms of security IT developers and half the hands go up. I'm like, why? Really simple things like keeping the record of your finances, your Social Security record, out of the healthcare system so that at least they're distinct, or figuring out ways to do our analytic processes, which we need to do on these really big data sets with, of course they're subject to necessary data right now, just the minimum amount you need, but how do we make that work at a systemic data level without it costing more money than the information we're producing can save us?
Now, you've asked the audience a few questions, and maybe it's time to turn the tables.
Absolutely.
And allow the audience to question you directly. So let's go with our first question.
I'm eager to ask about this last point that you made. I'm Adrian Gropper, Patient Privacy Rights. Yesterday we heard Sandy Pentland, who knows a little bit about data and hacking and big data, make a point about what he called a honeypot, that the most secure system is the one that distributes the data. And you made roughly the same point a minute ago when you said that the financial advisor may or may not be as secure as the bank, but the fact that each one had a relatively small amount of data meant that, again, to use Sandy's term, they were not really a honeypot and they couldn't do very much damage. What is happening now is that we are at a time when we have this growing tension between accounts that are controlled by the individual patient, and Apple with HealthKit and ResearchKit has raised the bar on that significantly very recently at scale, and continuing focus on regulated entities that Hipaa describes. What do you envision we can do in terms of giving individuals more control over their data, not relying on the limitations of Hipaa, this 20-year-old law, as you also said, so that in this next round of legislation that might be happening as a result of 21st century cures or precision medicine, we now merge these two realities that in effect would have a lot of good results, according to you and according to Sandy, if we could do it.
So I'm not going to comment on pending legislation, but I will give you a couple of insights from myself and my family as users, with the caveat that there's a a bug. That's not the caveat. With a caveat that, I work in the health IT regulatory business. My husband works in the health IT business. My mother uses her integrated system. So as a family, we may be having a different experience than the vast majority of Americans. And I particularly don't want anyone to assume that what I'm going to say about myself is presently available in every community in America, because we have so many communities that don't have broadband, where this hasn't really come to life at an electronic level. And you can ask me about the beet farmer next, which is one of my favorite stories. I think one of the things we can do is make sure that we are really clear as policymakers to ensure that people understand risk correlation. Sometimes it's called risk assessment, right? But the risk I present to my system if I log on through my physician's portal is pretty small, because theoretically I only have access to my own data, compared to the risk that might be presented by the office manager with that sticky note password. And that's a different level of risk, because that office manager may have access to the entire book of business about the patients, and that's even a different level of risk than a system administrator or a database administrator in a large organization might have. So that's one thing we can do. The second thing we can do is, as an industry within healthcare in particular, we can start looking at what are the practices that other industries have that we can adopt. So one of my security specialists he has this great metaphor. He says we're sort of stuck on M&M technology, hard on the outside, mushy on the inside. And what we really need, and I can't quite figure out the right candy metaphor, but the one I came up with was more like, a candy jar full of hard candies. Right? There's subsystems that are themselves hardened against intrusion. And you have to remember, I think I read in the paper that the Anthem breach was in part because their encryption key got stolen. So they were encrypting, but their key got stolen. So how do we, prevent? There's going to be bad people. We can do our best to prevent bad people from doing bad things, but sometimes bad things are going to happen. So we can look at other industries, and I'm working really hard to make sure that we, in my role, and my whole staff, is looking at what are the best practices from other industries like financial services that we can adopt. So an example might be, there's a difference in security between reading your own data, like downloading it is reading your data, and pushing data back into the EHR as patient-generated health data, and that's a project we're working on. Just like there's a difference when you log on to your online retirement plan, account, between what you're required to authenticate or show who you are to read about your balances versus actually make a transaction. If you want to place an order, you have to go through a bunch more controls. So we can look at those models and learn from them and maybe bring them into the healthcare systems. That sort of get at what you wanted? Okay.
We have about 5 minutes left for questions. Please, over here.
Thanks. I'm Andy Orr, and we've met.
Hi, Andy.
So, meaningful use in the stage 3 recommendations, there's talk about patient-generated data, and the doctors are now supposed to accept some kind of patient-generated data. It's a bit vague about that. So I don't know how much this concerns your office, but I wonder whether this data should be treated differently from doctor-generated data. Should it just go into the record and the doctor can aggregate it and release it as you've talked about? So are there differences now?
So I will say two things. One is we have, at ONC, we have an ongoing project to bring standards to patient-generated data so that we make sure a couple things happen. One is that data that's electronic and patient-generated has some technical standards in which it lives. Secondly, so that there's standards for what physicians are required to do with patient-generated data. And then I'd say, as a person, everything about me is patient-generated. When I go to my doctor and I tell them that my foot hurts, I'm generating that data. So I think that we have to also be really careful to make refined distinctions about what it is we're actually trying to systematize, standardize, and or regulate. Because when we talk to our doctors, we're generating data. That said, I think the idea here is that some patients and some physicians want to be in an active everyday dialogue about their data. Physicians may want to take advantage of Fitbits. There are scales that send your weight to your physician, which is really great if you have congestive heart failure, because a big increase in weight means you need to go to the ER and get the water pulled off your lungs. So there's some really great things happening in this space, and we need to facilitate the great things happening. Right now, the way it works is if you send a note to your doctor and he types it into his EHR or her EHR, or you tell your doctor something, it's part of the records that that doctor has that are subject to Hipaa. And it's not different because you sent it in a note, or it arrived in a Fitbit, or you told it to them.
But should this self-generated data, your medical data, wherever it comes from, however it arrives, should it have the same level of protection?
Well, right now it does when it's in the physician's records.
But if it's a Fitbit out there, it doesn't.
If it's in Fitbit's custody, it may not have the same protection.
But should it have the same protection?
That is an ongoing discussion. People have asked us a lot about that, and I think most people recognize, most people in the business recognize that that's not a regulated space. We do know that consumers think it is regulated by Hipaa, and that, again, it's something we're thinking about, we're trying to figure out, because, back to precision medicine, what if you want to send your Fitbit data to your researcher and Fitbit won't let you? That needs to be solved for, too.
Let's do lightning round. Final question, please.
Thank you so much. Very nice talk. I also very much enjoyed your...
This is my German researcher.
Exactly. So this is why she's here, actually, because you mentioned the broad consent. So law in Germany, or rather in the European Union, doesn't really forbid broad consent. It just brought such high requirements towards consent, towards specificity and information, that we no longer can use consents which we actually obtained. So that's the first point, just as a clarification. I guess I wasn't clear very much. But the second, you mentioned patient like me, and you said, well, you'd like to head into the direction in which, you know, you can actually decide, okay, I give Facebook my data, I give patients like me my data, and this is and I get something in return. And you compared it a little bit to the pharmacy or, I don't know, a physician selling your data. The problem which I have with this is, you know, I don't really have a choice there, and I already paid because I paid for, you know, pharmaceuticals, or I paid for the care. So if somebody comes and says, okay, Magdalena, would you like getting 20% off from your bill, and I'll just send your data out, I'm fine with that. I can make a choice, but today I can't. And I think the role of the government, be it European or an American one, would be to say, we can regulate it in some way in which we forbid it or allow it, but actually consciously. We don't do now, I think.
Yeah, so what I would say in America, there are regulations. Some people like them, some people don't. So those regulations allow the custodian to de-identify the data and then give that to other people, and there are rules about how much can be charged for that process. So that's the system we have, and that's the rules we have for the healthcare system in America. If those rules are not the right rules, then, you know, Adrian, the whole legislative process, that's for you guys as members of the public to take across the street.
We've run out of time, unfortunately, but
I can stay 5 minutes. I have 5 minutes if there's one more. So.
Just a 30-second.
Okay.
Bill Pugh, Marshall University School of Medicine. I wanted to clarify something, because in the Omnibus rule, there is a provision for longitudinal use of biosamples and EHR data within a scope, and it's only a couple of paragraphs long. We were actually envisioning using this within a scope in which the test applied is that the individual participant, the research subject, has to be able to anticipate that you might have done, or that you would have done, or could have done the procedures that you do. For example, if I biobank serum or collect DNA information, and I say I'm going to study, say, the progression of diabetes, I can't go out and test someone for pregnancy, but if the test is, or the research that I do on those bank samples or on the EHR data is within a scope that I've explained in the consent, I understand that that's allowed. Now, I want to make sure that we're not off base on this.
So I can't give legal advice. There is a provision for broad consent in the 2013 Hipaa Omnibus rule, and we know that the Office of Human Research Protections is, you know, in some stage of rulemaking relative to the common rule, which is sort of our academic, for those not in the U.S., the sort of academic way that we implement institutional review boards and that level of oversight. And eventually those two things will all become clearer as the Office of Human Research Protections finishes its work. But I agree with you. There is a provision in the Omnibus rule for this broad consent, and all I was doing was sort of contrasting that we need to make sure that whatever we say about broad consent, we think adults can make that choice, because that's the fundamental part of it, is that the person understands the choice they're making.
Well, the interesting thing is, going back almost 30 years, I was involved in a multi-center AIDS cohort study, and we did have such a broad consent from NIH, which gave us a considerable latitude. But what we're talking about, I know we discussed this yesterday a little bit, is we're either going to have to simplify consent, or we're going to have to, in longitudinal larger studies, people don't mind doing a 30-page consent if they know that we're following them and they know the scope of what we're doing over a long period of time. But I think people are running to the extreme of saying either we're going to throw consent out the window or this is unmanageable.
There are definitely wide, diverse opinions about that, and I know that the NIH team for precision medicine is working on what might need to be different. So that's pretty much all I can say.
So we're still waiting for some rulemaking rulemaking, though, in that first point?
Well, I mean, Office of Human Resource Protections did their advance notice of proposed rulemaking, which is a way of soliciting input from the public 4 years ago. They got 700 or so comments. Don't quote me on that, but it was a very large number of comments. They've been in the process that a regulator goes through of reading those comments, looking at the going forward policies. You know, nobody wants to make a rule every 2 years. We would all go crazy just trying to understand that, let alone the work that's entailed in doing rulemaking. So it's underway.
Appreciate it.
I wanted to thank you for speaking in straightforward, clear English.
Did I use too many acronyms?
Some acronyms, but as far as it goes from a Washington official, I think you did very well.
Thank you.
And I thank you very much.
Thank you. It's been a pleasure. Thank you very much for having me.